let's invite the next speaker, Audrey Telly-Rostock. Great. She's going to talk on the update on the medical and surgical management of dry eye disease.
Thank you. Here are my financial disclosures. Special thanks to, I don't know, it's can we go back? To the slide before. Anyway, special thanks to some of my colleagues in Cedars-Aspens for the help with this presentation. What we know, dry eye disease is increasingly prevalent. There are over 16 million people in the US. It's higher in women, increases with age. It's an inflammatory disease, and it is alarmingly increasing in younger populations due to digital devices. Parents, beware. We're seeing increasing dry eye disease in the pediatric population. There are also a number of algorithms that include many new modalities for the treatment of dry eye disease. And when I looked at these algorithms, I don't know why my slides aren't advancing here. There we go. I looked at these algorithms, and you could tell that a lot of work went into the algorithms. And in trying to decipher and distill the information, I felt as if, next slide, please. Well, when I tried looking at these algorithms, I decided that it was somewhere between looking at a manual for IKEA instructions and trying to decipher what the little emblem is on the dashboard of a rental car in a foreign country. It was just that clear. And you could tell, again, a lot of work went in here, but it's increasingly hard to decipher. What I decided to do was to try to distill the information for you in the commonalities among all of these different algorithms. And so there are a lot of different categories. Okay, we've got a new device here. There we go. All right, thank you. So the goals of therapeutic intervention are to normalize the tear film, decrease lacrimal gland inflammation, decrease ocular surface inflammation, stimulate epithelial healing, and also to restore the normal neural feedback mechanism to the lacrimal gland. Different categories of treatment include aqueous deficiency, evaporative based on goblet or mucin cell deficiency, blepharitis, both posterior and anterior, and then looking at co-conspirators. With dysfunctional tear syndrome, these are not mutually exclusive, and we often get an overlap in categories, and I will go through them. What I've done is I've highlighted for you in yellow the updated information here. Lid hygiene has been around forever, as we know, and yet increasingly there is evidence that hypochlorous solutions for lid scrubs are beneficial, and the increasing role of Demodex. There are now in clinical trials some new antiparasitic drugs for topical use, mechanical debridement, and there's a new toothbrush-like device that you can do an in-office lid scrub for lid debridement, and also paying attention to makeup removal as well as choice of cosmetics. This picture is just completely frightening to me. It will give you nightmares and keep you up at night. And it should at least help you remember that there is an expanding role in the pathology and treatment of Demodex. So you don't want that little person haunting your dreams or your patient's eyelashes. To treat posterior blepharitis, topical anti-inflammatory drugs, microwavable lid masks, and there's several on the market, thermal pulsation, and IPL. With thermal pulsation, which was first FDA approved in 2011, what's new is several thermal pulsation devices are smaller, they're handheld, they have lower price points, and here is Dr. Perryman demonstrating one of them. The efficacy of thermal pulsation, as we learned in the last talk, shows increased tear breakup time and meibomian gland flow. IPL is another non-laser light source using broad spectrum light, and mechanisms of action here include destruction of bacteria and microvasculature, which bring the inflammatory mediators, liquefaction of impacted meibomian glands, and it's most successful for dry eye patients with advanced MGD, telangiectasias, and rosacea. Efficacy of IPL has been shown in a number of studies, especially those by Drs. Gupta and Dell, which show increased tear breakup time and improved symptoms. And this is a really nice chart by Dr. Perryman that shows a lot of the different modalities and their mechanisms of action. When we move on to aqueous deficiency treatment options, you can replenish tears, you can use anti-inflammatory mediators, and what these do is really what you want to do is decrease the inflammation here and again replenish tears. So looking at tear replenishment, what's old is new again. Artificial tears, there's more varieties. There's some oil-based ones. Ocular inserts are making a comeback. And the really new thing is nasal neurostimulation. There's stimulation both internal and externally. There's pharmacologic now, nasal spray delivery, and that's again in clinical trials. And so there's a lot of exciting new modalities here. Again, the goals are treating underlying inflammatory disease. We all know about cyclosporin, lifitegrast, as well as topical steroids and their modes of action. Additional anti-inflammatory agents include amniotic membrane, and it comes in both cryopreserved, there's frozen, it comes in contact lens-like delivery systems, amniotic membrane extract, as well as autologous serum tears. Moving on to evaporative-based or goblet cell deficiency, again, the anti-inflammatories play a major role here. You can also use scleral lenses, and pay attention as well to lifestyle changes for patients, especially in the younger population with increasing use of digital devices. Just a note here to look at evidence of exposure keratopathy using moisture chamber goggles, and of course using all of the lubrication as well as surgical options that we all know and love. And just to mention here that in dysfunctional tear syndrome, you can have co-conspirators that can either exasperate or masquerade as dry eye tears syndrome, dysfunctional tear syndrome, and they can include all of the following. Pay a special attention to conjunctival cholasis, floppy eyelids, mucus fishing, as well as medicamentosa. Thank you, and I also want to thank some of my cornea co-conspirators.
Thank you.